I am pleased to say my goal, the university's goal, is one that today's luncheon keynote speaker, Jeffrey Bolton from Mayo Clinic, is planning to speak to this afternoon. Mr. Bolton will discuss how world-leading Mayo Clinic is viewing local, national, and international opportunities for growth in the midst of tremendous change in healthcare systems and markets. As Mayo celebrates its 150th anniversary, what an amazing milestone, how will the organization use its knowledge and expertise to start and grow business in Minnesota and worldwide? Jeffrey Bolton serves as Vice President of Administration and Chief Administrative Officer of Mayo Clinic. He is a member of the Mayo Clinic Board of Trustees and serves as Secretary for the Mayo Clinic Board of Governors. In collaboration with President and CEO Dr. John Noseworthy, he coordinates overall institutional strategy and stewardship of Mayo resources. Jeffrey oversees operations of Mayo Clinic's $10 billion, 60,000 employee physician-led healthcare system that treats more than 1 million people each year through its sites in Minnesota, Florida, Georgia, Arizona, Wisconsin, and Iowa. He also oversees Mayo Clinic's MMSI, a 233,000-member third-party administrator, and Health Traditions, a 36,300-member health maintenance organization. Mr. Bolton previously served as the Chief Financial Officer for Mayo Clinic from 2002 to 2013, where he fostered strategic alliances and business development, global business solutions, Mayo Clinic Ventures, Treasury and Investment Services, and all of the organization's internal and external accounting and financial services. Prior to joining Mayo Clinic, he held various finance-related positions at Carnegie Mellon University, the University of Pittsburgh, and the City of Pittsburgh. Please join me in welcoming Jeffrey Bolton to the stage.
Thank you, Maura, for that introduction. I really appreciate it. And congratulations to Life Science Alley for its 30 years of leadership in Minnesota of the life sciences. We appreciate the work you do, and we appreciate the partnership that you've generated with Mayo Clinic. Also very grateful for the partnership that we have with the University of Minnesota and the state of Minnesota. What I'd like to talk about today is how we view partnerships, the importance of partnerships in Minnesota, and also attracting partners from throughout the United States and the globe to transform healthcare, to be a positive disruptor on behalf of our patients. Before I do that, though, I'd just like to provide some overview of Mayo Clinic. As Maura indicated, we're located in 6 states. We have our main headquarters in Rochester, Minnesota, our largest facility. We also have a health system in the upper Midwest, western Wisconsin, northern Iowa, and southern Minnesota. We have destination facilities also in Jacksonville, Florida, and Phoenix and Scottsdale, Arizona, with another health system site in southern Georgia. We have just under 60,000 employees, just over 4,000 clinicians and scientists that lead our clinical, scientific, and education programs. As Maura said, we see about 1.3 million unique patients every year from all over the country, every state in the country, and over 135, cancel that. Okay, we're back on. Over 135 countries throughout the world. Our revenue last year was $9.4 billion, and all of the income that we receive is reinvested back into the mission of the organization. Just want to make a couple of points about our mission. We're a not-for-profit organization, humanitarian, and if you think about Mayo's reputation, it's really one of managing the sickest, most complex patients. It's a place where patients come to seek hope and solutions when none is available in their home communities. As we built our mission statement in 2005, we wanted to build on that foundation. And in addition to serving that tertiary, quaternary care patient population, we want to focus also on health and wellness. And it's something we've done for many years, but our focus now is really coordinating those services and offering them in a more streamlined way for our patients. The other distinguishing feature about Mayo Clinic is its integrated approach, integration across medical specialties. Our specialists talk to one another, refer patients to one another on behalf of our patients. Also, the integrated nature of our clinical practice, again, meeting the needs of our patients. Our research and development programs that are focused on finding solutions for the unmet needs of our patients, and our education programs that are focused on educating the workforce of the future. Now, as somebody mentioned earlier in the program, there's a lot of change. To them, it felt like it was occurring slowly, but the pace of change today in healthcare is happening more rapidly. Back in 1931, one of our founders, Charlie Mayo, indicated that the only constant is really, or only thing that's permanent is change. And that's so true today. And in that change, it creates challenges, but also opportunities. And as we look at the changing environment in healthcare, the one thing that we stay grounded in as we change our organization is our values. And our primary core value is the needs of the patient come first. And then you can see the founders' values that have a strong Franciscan approach. And those values have transcended time, the 150 years that we've been a healthcare provider. So today I'd like to talk about three key topics. One is just to give an overview of our perspective on the major factors that are influencing healthcare from a provider and a patient perspective. Talking about some of the strategies that we have put in place, using the knowledge that we've created, creation of value, and also focusing on financing and funding excellence. And then finally, talk a little bit about our strategies for growing life sciences in Minnesota. Many of you are familiar with all of the factors impacting healthcare today. Changing demographics, probably the most significant thing there is the aging of the population. Every day, 10,000 people turn 65. And what does that translate to? It translates to an aging population with more complex illnesses, more need of health care. There's also an opportunity, though, in terms of a population that is looking for solutions on health and wellness, and a population that has discretionary funding to support those activities. It also represents a significant challenge for our federal government in terms of one of the fastest growing entitlement portions of the budget. And that leads to government and payer responses to that. As you look at the forces, there's really a downward pressure on reimbursement, a drive for creating value in patients, but it will strain providers and also strain patients as more of the risk is moved from the payers, the government, to patients and providers. And again, this relates to patients taking more responsibility, more accountability for their healthcare services, and that shows up in some consumer factors, heightened transparency of pricing, heightened transparency of quality and safety issues. We view those as very positive forces. A more engaged patient population is one that will be much better off from a health perspective. We're also seeing significant new entrants into the healthcare market. As you can imagine, as 18% of GDP having grown rapidly, now stabilizing a bit, it's a real attractor for businesses. We're seeing retail organizations get into the care provision business. Many insurers are acquiring providers. So there's significant turmoil in the competitive markets space. And then as you saw today with some of the companies that were featured, rapid development and deployment of technology, which again creates a great opportunity for partnerships and improvement of healthcare. As we've looked at healthcare and the challenges that we face, we've identified 3 areas that we're focusing on. One is the fragmented nature of healthcare. If you think about trying to navigate the healthcare system, where you have a primary care or a family physician refers you to a specialist who may refer you to another specialist, and there really isn't a lot of conversation between the specialists, and individuals are challenged navigating that fragmented environment. As I mentioned earlier, Mayo has always focused on an integrated approach, helping patients navigate that. And one of the things that we've used is our knowledge as a healthcare provider to help that navigation. And so as we're facing the future and some of the initiatives that I'll talk about, we're using knowledge as an integrator on behalf of our patients. Uneven quality. There's a quote from a politician once that said, healthcare in America is represented as islands of excellence in a sea of mediocrity. We're really focused on driving excellence in healthcare, driving value on behalf of our patients. And value, as we define it, is quality, positive outcomes, safety, and service for our patients over cost. So we're driving down cost and improving quality. Talk about some strategies there. And then the excessive spending in healthcare, overutilization of services, and the approach that we're taking there is investing in excellence. So if you look at some of the examples, if we could go back to the previous slide, that we're using, we've created a database that captures the knowledge of Mayo Clinic, all of its specialties, develops protocols and care pathways that our physicians can use. One specialist can call up protocols in another specialty area if there's an interest. Historically, we used telephone and essentially curbside consults, we called them. Now we're using data to help, and we can always use the phone or an e-consult when necessary. Now, as we've thought about building this asset for our organization, we thought, what if we extended that to other healthcare providers around the country? And as a result of that, as we were looking at the mergers and acquisitions that were occurring in healthcare, we decided not to pursue acquisitions in this most recent time period, but rather use our knowledge as an integrator. So 150 years ago, we began in Rochester, Minnesota. About 25 years ago, we built a health system around the Rochester campus. We built de novo sites in Arizona and Florida, and then just recently added a health system site in southern Georgia. But what we've done now is we've created a network of providers that we provide knowledge-based services to. And over the period of about 36 months, we've generated about 31 of these partnerships. And what we're able to provide those providers with is our knowledge base. We provide them with e-consults, virtual e-tumor boards, and a variety of other consulting services that they can use to really stay viable within their communities. It's been a very successful program. What we found is that 80% of the e-consults that we conducted with providers in these healthcare sites were able to be treated within their home community, not requiring travel to a tertiary or quaternary facility. The other 20% we were able to provide access to Mayo Clinic in a very streamlined fashion. So again, coordinating and integrating care across the country through this knowledge asset that we've created. Another example is our EICU, which basically we have a command center in Rochester that provides services to ICU units located in typically rural community hospitals. This basically provides two things. One, it addresses a gap in the number of intensivists that are available nationally. It's anticipated by 2020 that there will be about a 35% shortage in intensivists. It also provides a bridge for a skill gap that may exist in those communities, the ability to attract and recruit the best, and also physicians that may not have seen some of the traumas or illnesses that present in the EICU. Through the pilots that we've run, we've been able to reduce mortality in these community hospitals very significantly. Again, extending our knowledge. The third example that I'll give is a company that formed out of some of the development decision algorithms that we used in the ICU, the ORs, and the ED, emergency department. The company's ambient clinical analytics. And what it does, it addresses the information overload that a physician faces when they're looking at all of the physician and nurse face when they're looking at all of the information on monitors. Basically, this is an aggregator of information and sniffing out issues deteriorating patients before they would be become known to the care providers. Very significant improvements in patient outcomes, and again, as you would expect, reductions in cost. In terms of creating value, I'll give 4 examples here. The first is the creation of the Center for the Science of Healthcare Delivery. And I should preface this by saying that, as far back as 1907, the Mayo brothers saw the value of engineering in the practice. They hired a physician, Dr. Henry Plummer, who was also an engineer. And since that time, have embedded engineers in the practice, looking at ways to improve care delivery and patient pathways. The Center for the Science of Healthcare Delivery is designed to really identify best practices, the accumulation of big data, looking at care processes and results, and being able to demonstrate best practices. When we formed this center, the objective was first to define value. It was an elusive term. It's used all over, pay for value. But the center was really designed to define it, demonstrate it, and improve value for our patients. I would also say that this is a great, the center has established a wonderful partnership with a Minnesota-based company, Optum, and created Optum Labs. We currently have 15 partners that are contributing data, doing analytics. Currently, there's 150 million claims lives included in the data set and about 30 million patient clinical lives included. We're able to join those and, again, look for best practices and measure results. Just an example of one area that we've done some research on in CV surgery. At one point, our CV surgeons all felt that they had the best way of conducting surgery. But the team got together, and if you had 5 surgeons, probably 4 of them were not doing best practices. What they did was they standardized practices over the course of over 1,000 patients that they looked at. And what they found was that for about 70% of that patient population, you could actually standardize the surgical protocol. And the results, the outcomes were very predictable. And in doing that, they improved outcomes, reduced length of stay, reduced 30-day readmissions and drove down costs by about 15%. So again, better patient outcomes, lower cost. For about 20% of the population, and again, you would expect this in a Mayo Clinic hospital, they found that because of the complexity of the patients, the comorbidities, that each one really did require a unique approach to the surgery. And there was about a 10x cost associated with that approach because they were so serious. Now, one of the problems that we face is when the public looks at our data, they look at the average across that, and you come up with an average that looks like this is a very expensive place to do cardiovascular surgery. However, if you segment the populations and you look at those that we're able to standardize, you see a very high value, great outcomes, lower cost. And then for the remaining population, you see good outcomes, but very expensive because it's a significant utilizer of services. Another example of creating value is our Telestroke program, which began in Arizona, but we've now extended across the organization. And basically, again, it's the ability to create stroke center-like results in rural community hospitals, with the central stroke center located in one of our 3 destination practices. Using robots, high-resolution monitoring, we're able to provide advice and support. And in the case of stroke, fast action is very critical. The final example that I'll provide here is really the frozen section example. And again, this goes back probably to the early 1900s when Mayo Clinic located pathologists in the lab very close to the surgical suite. And essentially what we would do is when a tumor was removed, the pathologist would look at the tumor while the patient is still in the OR anesthetized and determine that they removed all of the malignant part. So they'd look at the fringe, and if they didn't, they would go back in and remove the remaining amount. And that sounds pretty basic, but there are very few hospitals across the country that do that. And through a research project that we did, we found that those organizations that did not do frozen sections were 4 times as likely, the women were 4 times as likely to need to go back in for re-operation within 30 days. Now, that's a very significant impact, and that was for lumpectomies with breast cancer patients. So again, it's expensive, and it's a devastating result for the patient that we were able to address. The final part that I'll cover is the excessive spending, and again, investing in excellence. And this is where we're really talking about translating discovery into the practice and into the commercial realm, making it available for patients everywhere. I'll talk about the discovery to translation path in a minute, but I'd also like to emphasize 2 centers that we created recently, and these supplement our centers in cancer and healthy aging and a variety of other areas. We have many centers. The Center for Regenerative Medicine, again, helping the body heal itself. We have a strong focus in cardiology, lung, musculoskeletal, regenerative medicine, and other areas. Again, using stem cells and other engineered cells to help the body heal itself. We have a clinical trial, first in human clinical trial in cardiology that'll begin very shortly. The other center is a Center for Individualized Medicine, using the human genome with diagnostics to really tailor therapeutics to the individual. We're seeing significant progress in this area in cancer and other diagnostic tests. Recently in psychiatry, launched a company that was able to identify appropriate treatment for depression. So again, significant examples in advancement. Now, as we think about the path of discovery to translation, I talk about Mayo Clinic as a research enterprise. We spend about $650 million a year on basic to clinical research. About $280 million comes from Mayo funding sources, with the remainder coming from extramural funding sources and philanthropy. And then on the other end, the translation, getting these discoveries to the clinical practice, you have the usual suspects. You have venture capital, private equity, industry, and the public markets. And as you're all familiar, the path from discovery to translation is riddled with the valley of death. Many of those discoveries never make it to the marketplace. What we've tried to do at Mayo is to bridge that with some interesting financing strategies, internally driven. The first one, CODE, is from our Center for Innovation. And basically, this is taking ideation and primarily focused on clinical practice, but there is some IP development. But these are awards of about $50,000 where a clinician or a researcher, investigator has an idea, and it allows them to take it to the next step, possibly even to prototype. It's been a very successful program, as I mentioned, especially in terms of clinical changes to the clinical practice, testing new delivery systems. We have a fund called the Mayo Clinic Ventures Fund, Innovation Fund. And this is basically taking a portion of the proceeds from our commercialization and reinvesting it, creating a green fund, essentially, to reinvest in new technologies. These investments, again, these are promising technologies coming out of the clinical practice, are typically in the $200,000 range. Now, these funds are allocated in a very disciplined manner by our Mayo Clinic Ventures group and milestone-driven. If an idea doesn't hit milestones, the funding is completed, or it goes away. It's discontinued. But as they progress to commercialization, then we're able to link them with these other funding sources to commercialize. The President's Discovery and Translation Fund. This is, again, managed by Mayo Clinic Ventures, but includes a scientific, a business, and a clinical review of the technology. These investments, again, these typically run in sequence, are in the $300,000 range. Again, investing in promising technology, milestone-driven. If you look at the Mayo Clinic Ventures and the Discovery Translation Fund over the last 7 or 8 years, we've invested in about 191 technologies and have commercialized about 101 of those technologies. The return on capital was about 1.8x, so we view it, especially starting out with very early stage, as a successful program. The next one, the Benefactor Innovation Program, is one we're in discussions with primarily grateful patients that want to see impact of their dollars, and basically talking to them about getting promising technologies to phase 1 clinical trials. This is still a big gap for us, and there's quite a bit of interest in that program. And the final fund is the Ventures and Growth Fund. This is managed within our investment portfolio by our Treasury group in partnership with our Mayo Clinic Ventures group. It's a $100 million fund. We've drawn down about 34% to date and have an IRR of about 14%. So again, a very successful program and getting through that gap. Now, as we look at these opportunities, there are a number of other things going on at the institution. First, we've made some changes in policy. Clinicians and investigators are now able to hold ownership positions in medically related companies. We've also reviewed and revised our policies in terms of collaborations with industry. We're open for business, essentially, partnering with corporations, again, within Minnesota, and also trying to attract industry from outside of Minnesota to partner with us. We've been blessed with many Minnesota relationships, and also with attracting companies from outside of the area. The other thing that has been going on, many of you have read, I'm sure, about Destination Medical Center, and this has been tremendous support from the state, recognizing the economic potential of our patient population. About 40% of our patient population comes from outside of the state. And then the growth in some of these business developments in Rochester and broader Minnesota. And so this is a very exciting time. We're expecting over the next 20 years about $6 billion of private investment in the Rochester area. And the state and city will provide about $587 million to support infrastructure to support that growth and development. So many people view these as very challenging times in healthcare. We view them as great opportunities to continue to improve the care that we provide our patients. And again, we look forward to partnering with many of you as we develop benefits for our patients. With that, I see Goldie Gopher has arrived in the building, and I'm going to close for the day. Thank you very much.